This episode of Adventures Through the Mind is brought to you by Deep Sky Coffee, single origin beans locally roasted in Tampa, Florida. If you head to jameswjesso.com/coffee and use the promo code Jesso, you will get 10% off your order and give 5% back to psychedelic research. Okay, hello everyone. Welcome back to Adventures Through the Mind. I am your host, as always, James W. Jesso. Now, many of you listening are probably already aware, because you're likely interested enough in psychedelic culture and psychedelic things happening to have been following the news, which is that this year, 2020, 4 terminally ill patients were granted legal exemption by the Ministry of Health, Canadian Ministry of Health, to have access to psilocybin-assisted psychotherapy, specifically for addressing existential distress, end-of-life distress. And as a consequence, in August, the first ever legal non-research dose of psilocybin was given to a patient here in Canada. This was the result of very hard work on behalf of an organization called TheraPsil, a coalition of healthcare professionals, patients, and advocates dedicated to fighting for the rights of Canadians facing end-of-life or illness-related distress to have legal access to therapeutic psychedelics. Since that first session in August, they have even granted and facilitated therapy for someone who is a non-palliative, a non-terminal patient. They got legal exemption to provide psilocybin-assisted psychotherapy to somebody suffering from trauma. Now, as you can imagine, both of these things are incredibly significant events and legal precedents for the ongoing integration of psychedelics into the Canadian medical infrastructure and the integration of psychedelics into the practice of medicine, the medicalization of psychedelics. And so it's exciting and it feels exciting. I don't really have a lot of nationalistic pride, to be honest, but there was whatever tiny little bit of it still exists inside of me was sort of like nicely stroked by Canada being the first country to do this since, the draconian criminalization of 50 or so years ago. So yeah, I mean, that's exciting. It is exciting. And that's why I have the TheraPsil team here on the show today. I have the man who facilitated these therapy sessions, Bruce Tobin, who has been helping move this process along for a few years now, as well as he's joined by the medical director, Sean O'Sullivan, and TheraPsil's CEO, Spencer Hockwell. So the three of them join me here on the show for what was supposed to be a psychedelic cafe, but the cafe vibes didn't really catch. So it ended up being more of a traditional interview style. I cut out most of the cafe stuff so that's not interrupting to the process. But they join us. We are joined here on the episode with them to talk primarily about psilocybin for end-of-life distress and the legal arguments behind the access to psilocybin for terminally ill or non-terminally ill patients. So this was recorded a few months ago. It was actually recorded before the trauma exemption happened. So we don't actually talk about trauma or that process at all. We talk mostly about, like I said, the legal argument for psilocybin to be provided to patients here in Canada, as well as because we talk so much about the role psilocybin can play in the alleviation of end-of-life distress. We talk quite a bit about dying and life and meaning around one's dying time and where psilocybin fits into sort of helping to resolve or clear or change or alter, helping to basically provide a greater sense of deeper support for the complexities and challenges of being in one's dying time. Now, I want to comment on how the framing for this conversation is heavily nested in psilocybin as a clinical medicine for North American people. And because of that, the language and the framing and the discussion, I think, is incredibly valuable to the larger discourse around integrating psychedelics into present medical infrastructure. And because of the scope being so specific, I think there are some paradigmatic, is that how you say that word? I think that's how you say the word, limitations to the larger wondering about psilocybin's role in a meaningful life and a meaningful death that may or may not, be discussed here. And I have more to say about that, and I'm going to write it up in the show notes to this episode. If you head to jameswjesso.com, look for episode 133, you'll find those further thoughts written down on the show notes rather than further in lengthening these often quite long intros. So that's that. I have two things to say before the actual podcast begins. And the first thing is that I want to apologize to you because something is happening with Bruce's audio that not every time, not the whole time, but a few times is just brutal to hear. Like I did my best and it's still brutal. So prepare your ears. It doesn't happen too many times, but it does happen. So hopefully it won't be too jarring now that I've told you, and it won't detract too much from hearing what Bruce is saying. The second thing I want to say is thank you, patrons. This podcast could not exist without your generosity and your commitment to supporting the financial requirements of investing money, right? And also time, a substantial amount of time into producing this content. So thank you very much, patrons. Thank you. The people who's listed on the screen here on YouTube have been giving significantly, some of which for quite some time. So an extra thanks to those people. Their names are also listed in the description to this episode, wherever you might be checking it out. If you are not yet a patron and you would like to become one, I would very much thank you for doing so. And you can do so by heading to patreon.com/JamesWJesso. Other support options include single donations on PayPal or through cryptocurrency, and the links to do so are listed in the description to this episode. Thank you very much. Enjoy this interview with the TheraPsil team here on Adventures Through the Mind, episode 133. So starting with myself, my name is James Jesso. I'm the host of this podcast, and I am here, and I have brought this together because there's a variety of different places in society that intersect on the potential of psilocybin therapy for dying patients. And I think that there's a great conversation to be had around that. And so that is why I'm here and why I have brought this together.
Okay. My name is Dr. Bruce Tobin. I've been in private practice in Victoria, BC for 40 years now as a psychotherapist, specializing in treatment of depression, anxiety, and emotional trauma. I'm the founder and chair of the board of TheraPsil, which is a nonprofit advocacy group promoting patient access to medical psilocybin. And in the past month, I have provided Canada's first two legal psilocybin treatments to terminal cancer patients suffering from end-of-life distress. And both were wonderfully successful.
My name is Sean O'Sullivan. I'm an emergency room physician, and I also practice psychedelic psychotherapy. Up until quite recently, I've been doing solely with ketamine. But since psilocybin has been legalized for patients with a terminal diagnosis, we are beginning to treat patients now with psilocybin mushrooms for that diagnosis.
And my name is Spencer Hawkswell. I am the CEO of TheraPsil based here in Victoria, BC. I've experienced in organizational management. However, this is the first nonprofit that I've ever been working on, and helped Bruce, meeting him back in September of 2019, over the past about 10 months here, building TheraPsil into what it is today, which is, as mentioned, a nonprofit healthcare coalition focused on four main pillars. The first is access to treatment. The second is professional training. The third is education to the public. The fourth is research. Thanks for having us, James.
Great. Thanks, everyone, for coming. Why does access to psilocybin therapy for dying people matter?
Well, access to psilocybin and psychedelic medicine matters to dying patients because these compounds have the ability to open the patient's mind to realms of the unconscious which are not available through any other means, perhaps a few other means like powerful meditation. And in those spaces of the expanded psyche are all kinds of gifts and benefits which patients can access. And these experiences also bring them into profound contact with their spiritual life and the collective unconscious, where a great deal of energy and healing lies. And there are no other medications in existence which have this capability.
Awesome. And I believe that psilocybin access for dying patients matters because of a fundamental human right here we have in Canada, and that is access to our medicine. It's become abundantly clear in the past 10 to 20 years in Canada with access to things like cannabis and ayahuasca, as well as a host of other medications. I think that the fact that these patients are dying helps us, and it acts as an amplifier and accentuates extreme situations where this principle needs to be applied. So when we look at dying patients, you'd think that someone at the end of their life who has access to all of these other medications and to medical assistance in dying should also have the right to something like psilocybin, even if the research is not abundantly clear, that it should be made accessible on the basis of human rights. And in our case, that is the right to try.
I'd like to expand on this idea of human rights to provide a kind of a big picture context here. In Canada, we have a document called the Charter of Rights and Freedoms, and Section 7 of that document states that everyone has the right to life, liberty, and security of person. And Canadian courts have ruled over the last 20 years in two landmark cannabis cases that the absolute prohibition of cannabis by the Controlled Drugs and Substances Act contravenes the provisions of Section 7. The famous Parker decision in the year 2000, the court ruling was that liberty includes the right to make decisions of fundamental personal importance, including the choice of medication to alleviate the effects of an illness with life-threatening consequences. Deprivation by means of criminal sanction of access to medication reasonably required for the treatment of a medical condition that threatens life or health also constitutes a deprivation of security of person. So we have a situation here where we have a fundamental right as Canadians to medical autonomy. That is the right to make our own medical choices regarding treatment and the right to choose our own medicines. I think that's the big picture context in which this discussion ought to be situated.
Given that I'm not coming from a place of providing therapy or being in a clinical setting, but more from a place of being someone who has has a deeply meaningful relationship to psilocybin from a personal, spiritual, personal development kind of place. And, as one of those people who is eventually going to die in my life, I also recognize the impact of my uncertainty and fear and deep grief and sadness and all the rest of the intense emotions that come around and come along with the idea that at some point I'll have to fully and completely say goodbye to my life, and knowing that the latter exists and the former has brought so much clarity around the latter for me, and capacity to be with difficulties and to have a sense of what it is I'm trusting in and surrendering onto, at least from the example of my psilocybin experiences, has been helpful in me resolving some of the anxiety that I have simply about the fact that I'm going to die. And that doesn't even exist inside of the context of knowing, somewhat definitively that it's sooner rather than later, and possibly much, much sooner rather than later. And I already know what it is that's likely going to kill me. So, or that I'm likely to die of. And so thinking about the role psilocybin and knowing scientifically the role psilocybin plays in a lot of the resolution of the emotional, spiritual distress around dying, it seems that it seems sort of also echoing the sort of legal charter rights position that it's completely unreasonable that we would not institute psilocybin for dying people as a medical procedure, especially given the vast amount of information that we have about how safe it is as a physical molecule that affects physical and psychological processes.
Well, the comment that I would like to just pick up and run with from that first round, James, is to emphasize your point about the safety of psilocybin. The two questions we have to ask about any medicine that's being introduced into clinical practice is, first of all, is it safe? And certainly, is it efficacious? And I challenge anyone to find a medication that's as safe as psilocybin in terms of its physical safety profile, and as long as the screening procedures are done correctly, its psychological safety profile. So, and then on top of that, we are working with people who have a very definite time horizon anyway, and not that we should be cavalier about the application of any form of therapy to that patient population, but certainly the patients themselves within that cohort need to be given a much larger degree of laxity about the kind of restrictions we would place on a medication. So the safety of psilocybin has been well established. And as Bruce has pointed out, its efficacy has been well established. These psychedelics in general, and psilocybin in particular, have been used for myelemia and have been studied since the mid-1960s.
Something I'll attempt to add there too is, certainly as a society, and also perhaps our medical community, is moving away from our ability to take risks and lead innovation with risk-taking, because it is risk-taking and exploring the unknown which leads to new discoveries and innovation. So giving medical professionals and patients dignity and risk, being able to experiment with something like psilocybin, and there are many other drugs that are used off-label every day. This is where research is led, is by the clinicians, not always the researchers, especially when these substances are available off-label. This is certainly a world we need to move back into, and I think psilocybin is a perfect example of how, given the right conditions, therapists and doctors and psychiatrists and dying patients are able to again have dignity and risks to experiment with something to resolve their end-of-life distress that at present is completely treatment resistant. So it is the next logical step in treatment, and it's a very reasonable prescription to give someone in their position.
The safety and risk issue is one that often comes up early on in a discussion with a person who's newly contemplating the possible use of psilocybin. There's culturally, we're steeped in still a good deal of fear about psychedelic substances. I want to just refer directly to some of the research around this issue of safety and risks, though. In 2016, the Johns Hopkins team concluded that, quote, no serious events, adverse events attributed to psilocybin administration occurred in their study. And the NYU team said, psilocybin has a well-established physiological and psychological safety profile in human laboratory and clinical research. There were no serious adverse effects, either medical or psychiatric, in the trial that were attributed to psilocybin. So really, we are dealing with a very safe substance here. And that doesn't mean that the psilocybin experience itself is going to be necessarily an easy journey. The Hopkins team points out in more than one paper that up to 40% of their research subjects had moments of extreme anxiety, sometimes involving paranoia. The important takeaway from that fact, though, is that virtually all of those patients acknowledged that those difficult experiential times in their journey were very important to the outcome resolution of their journey, and virtually none of those subjects regretted having had the experience the following day.
I think something that I'm wondering about is this sort of weird dichotomy that comes up for me from a non-clinical for dying patients situation, which is that, you know, it's within certain conditions, it's totally legal and appropriate and okay for me to own a gun, go skydiving, go horseback riding, or even practice competitive fighting. And yet it's not okay for me to eat psilocybin and have an adventure in my own mind. And I'm wondering about I wonder about what is behind the ready and willing prescription of something that is knowingly dangerous, like benzos, for example, for this type of anxiety, but then is immediately reluctant or dismissive of something like psilocybin when, and I mean, this is an assumption that I'm making, but I think it's a fair assumption, which is that all the care providers inside of palliative care actually do want the best for their patients and do care about their patients' well-being. So as clinicians, I guess Spencer is a CEO and not necessarily a clinician, but I wonder about what might be going through the mind of the person. Like, why does this situation exist, essentially?
Well, I think that's a basic question that pertains not just to the care of dying patients, but actually to the care of psychiatric patients in general, and the basic modus operandi of psychiatry these days, because the basic treatments that are available to psychiatrists and the paradigm under which they work are treatments of suppression and a paradigm of suppression. And so anxiety and depression in modern psychiatric care are seen as illnesses, diseases. Anxiety is a disease. It's got something to do with something up here. And depression is a disease, and it has something to do with something back here. And we're becoming increasingly sophisticated in discovering what those somethings are, where in the brain these pathways are disturbed or chemical transmissions are disturbed. But anxiety is not a disease. Anxiety is a symptom. And depression is not a disease. Depression is a symptom. I've been in practice for over 50 years, and a large part of that time has been spent in psychotherapeutic practice. And needless to say, a large part of that time is spent in dealing with anxiety and depression. And we are dealing with, particularly with women who have a lot of problems, more psychological problems. They present with more psychological problems than men. It is very rare that we find that a person with severe and profound depression, particularly if they've tried to hurt themselves, has not been sexually abused in some way in childhood. And we have met people in our practice who have been in the cycle of therapists and psychiatrists, I should say, and psychiatric therapy for decades with depression, and nobody has asked them why are they depressed, and nobody has taken a history of their past. The diagnosis is depression. That's the disease. I give you something to stop that depression. And if you come into my emergency department with abdominal pain, I can give you morphine until your appendix ruptures and you die, and you'll feel no pain. And a similar analogy is applicable to people who suffer for psychological illnesses. There is usually a cause, and it can be found, and you need to get to the cause and examine it and explore it and release it if you want to cure people.
I can also just briefly speak. I think, what you were talking about, James, why you have the right to own a gun, why you have the right to skydive, why we have the right to, if you look at David Nutt's work, why we have the right to alcohol and tobacco, which are some of the most dangerous substances we know of as far as harm to users and harm to yourself, is that these have a cultural place, in our society. We use these, everyone knows them, they're comfortable with them. Back to dignity and risk, life is about taking risks. Life is about enjoying, right? And you need to enjoy life by, sometimes having a drink, sometimes having a smoke, going skydiving, fighting, watching fighting, driving your car. These are all risks. However, when we start to mix this into a scientific community, which, as Sean was saying, is more focused on suppression and may not have their bearings straight, then we start to run into problems where all of a sudden we can't take risks. And all of a sudden, medicines that were made taboo 50 years ago because of some presidential campaign or for whatever reason, certainly it wasn't because of a plethora of research aiding to how dangerous these substances are. Those things are really hard to undo within institutions. And many institutions are self-protecting and do not allow for the most innovation. So it's a completely different context. And if psilocybin perhaps had a long history, longer than the 50s and 60s allowed for, of benefits and research and clinical use, then perhaps we wouldn't find ourselves in the same situation we're in today. But certainly, research and the natural progression into normal clinical use was truncated back in the 50s and 60s because of these laws. So when you're trying to undo that, it takes a lot of time. Undoing bureaucratic processes and silly laws is much more difficult than creating them. And that should be a lesson for us. I think it's why a lot of people want to be careful with the reintroduction of psychedelics, and rightfully so, because if mistakes are made, their consequences are going to be long lasting. So I hope that sheds a light on why, you may be able to do some other dangerous things, but relatively safe treatments, may take so long to reintroduce.
I'd like to return to this theme of fear of psychedelics and psilocybin in particular. And I suspect that a lot of the fear has to do with loss of control. We live in a culture that is steeped in the value of having control and being in control. And one of the things that seems to be a universal feature of psychedelic experience is that successful psychedelic experience involves the letting go of control. And that is regarded as a very scary thing for many citizens. And it comes from not only from the culture, I think, but from the Western religious tradition that we all have been steeped in as growing up in Canada, the idea that being righteous involves control over certain impulses and instincts and desires, so that successful living traditionally within the Christian tradition had a lot to do with maintaining control. And so the folks that have the greatest fear about taking psychedelics themselves also are the ones that seem to have the greatest fear about either losing control or letting go of control. That's not a value that they can buy into. And then there's also the issue of social control. Back in the early 70s, Richard Nixon labeled Timothy Leary, the primary evangelist of psychedelics at that time, as the most dangerous man in America. And I think that's because he saw psychedelics as something that was going to enable the young people of that day to slip out from under the control of the political establishment of that time. So when it involves loss of control for myself, or loss of control of others for a government, we're immediately into a climate of fear.
I also, as you're speaking there, I thought about how much the sort of culture of how that control expresses itself or is sort of encouraged to express itself comes in, and thinking about North America as being stuck in this like Protestant hangover of like the control that's necessary is to basically control all impulses to consume for, say, pleasure or whatever, so as to entirely focus on the value of work and of productivity, and how things like, and that the productivity is necessary to keep going the economic system, and the economic system or the economy as being sort of this primacy of achievement for a society to have a good economic system. But inside of consumer capitalism, that means that anything that interrupts or threatens the tendency of people within that society to prioritize material gain and work productivity is a bad thing. And in many ways, I think psilocybin can be a bad thing to that, because it really has a person check in with themselves about what is or isn't working and what is or isn't valuable in their lives. And for a lot of people I've known, the result of that checking in is something along the lines of recognizing, like, whoa, I think I'm quoting or paraphrasing Stanislav Grof here. It's like I've been climbing this ladder my whole life, and it's just against the wrong wall. And so I wonder about how much the dissolution or disintegration of culturally established the culturally established meaning of one's life, which in some sense is also the meaning of one's death, is involved with the resolution of anxiety with a terminal diagnosis.
Sorry, James, I'm not quite sure how the question related to what you said beforehand. Did they tie in somehow?
Well, I thought they did. It's around the dissolution. I mean, it was kind of like a lateral step. I was using one thing as a pathway to get to the next thing, but it's around how psilocybin is threatening to the established political, economic, social system because of it challenging. So you've got it. I don't have to.
Okay.
Yeah.
So I would say my impression is that fear on the part of regulators and governments was far more present and more rampant in the 1960s than it is now. I mean, when you deal with government officials and mandarins in the various departments, you understand that they're really quite smart people. And it's been my experience that the more superior an individual is in their department, the smarter they are, and they know what's going on. Their job is to monitor society and feedback to the government, and I think they do a very good job, a very accurate job. So in the 1960s, when the flower people were spilling out into the streets, and when that whole process was amplified by the media, because it wasn't as rampant really as it appeared to be, then I could see that mandarins and bureaucrats and legislators were paranoid that their society was falling apart, and their job is to maintain their society. I think that's much less of a concern now among the people with whom we're dealing, and I think it's much less of a concern now with the politicians with whom we are dealing. They're much more aware. They know that we've had 50 years of psychedelics being deeply embedded in our society. There's a lot more than 50% of kids going through high school will have taken something at some point in their lives. And the sky has not fallen. And the other, they also have looked at the research, because again, that is their job, and they see that these compounds are useful, particularly in very difficult to treat conditions. And the first of these to break through, of course, was the MDMA and PTSD research with Dr. Mithofer and his wife. MAPS has done a tremendous job of alleviating those kinds of concerns. So I don't think there are too many people in government now who think that the economy is going to fall apart if kids are allowed to take psilocybin, or if adults are allowed to take it, or far more importantly, from our perspective, if physicians and psychiatrists and therapists are allowed to use them where they're needed. Because, of course, the big paradox of what happened in the 1960s with the banning of psilocybin and LSD and other compounds such as that is that, in contrast to powerful opiates, which are also scheduled and banned, the opiates can be used in medical practice. And we would not be able to practice medicine without opiates. And the same thing can apply here. The illegal market is going to do what the illegal market does. We're only concerned about what we're applying as clinicians.
I think I'm going to jump in quickly here, because Sean's response sort of illuminated where my question was going that wasn't clear previously, and then brings up another question. The question that I had previously was situated in this acknowledgement of the dissolution of culturally established paradigms in one's mind through the use of psilocybin, and then what the thinking was in this group around how that same action is responsible or involved in the resolution of terminal anxiety. And then it also brings up the second question, Sean, what Sean was saying there about how, regulators, politicians, whatever, they recognize things much more sharply now, and yet there's still this strong urge, or it's still this massive hurdle. And TheraPsil went through something like more than 100 days waiting for a response to get access for your patients. So those are the two questions. I think the first one is one that feels really juicy for me, but either of them feel pretty interesting.
I do agree that there's far more openness to psychedelics now than there was, say, in the mid to late 70s, shortly after psychedelic research had completely closed down, partly because we know so much more about the substances now, and there's a much greater degree of openness, I think, in the professional community of therapists. Back in the 60s, there were new drugs coming on stream for the treatment of depression and anxiety. The SSRIs began with Prozac, and a tremendous amount of hype about how that would revolutionize the treatment of depression. Well, it turned out not to be so. many of us who have worked in practice for 40 years, we know all too well how much paucity there is in our repertoire of medicines and clinical skills and techniques. So many of us have come to look very closely at psychedelics because the things that we learned in graduate school that were supposed to prepare us adequately to treat the wide spectrum of patients that come through our doors, we've come to see that very little of it works for many, many people. And so there's a new openness to look at psychedelics just because we recognize how much our I'm sorry, I'm tying up here. We recognize how little efficacy so much of what we were taught has.
I want to comment on what I really agreed that Sean was saying, and perhaps specifically bring it back to these cultural paradigms that you're talking about, James. I think that in the past, in the 50s and 60s, when psychedelics were first made illegal, I don't believe that there was an educated, or that those who sought to protect these cultural paradigms were adequately educated on how psychedelics work. And the reason I say that is because, even today, if you ask someone how they're doing, the first thing they may say is busy. And maybe this is what you're getting at, is that the root of anxiety is in our misconceptions of our meaning of life and death. And so, yeah, when you ask someone, how is your day? And they say it's busy, work's busy. It's like, you're probably far more interested in how is their actual life? What are their relationships like? How is their life meaning? And meaning is really, really important. And I think Sean might agree that when you ask people with severe depression and anxiety, and Bruce may agree too, when you ask them, how are you? How are you doing? Or even what do you think of yourself and meaning? I mean, the answer is depressing. And so we may have moved away from that. And I think that, in all honesty, I think some psychedelics may reinforce very positive cultural paradigms that took us and our civilization thousands and thousands of years to develop. Such as the fact that, healthy families are really important in building meaning. Such as the fact that, working together and caring for your neighbor is really important in building meaning in your life. This is the logos that we may have lost in the last, 50 or 60 years, as we've moved away from a lot of, traditional ways of doing things, as we've become more atomized with technology, taking away from and replacing what used to be real social interactions and real places of meaning in our life. So, I mean, in all honesty, I really think that psychedelics may have the ability to really positively reinforce some very, very positive cultural paradigms that make people feel like they have meaning, that they belong. And so I think that the politicians know this as well. I think they've seen the research and realize that you don't get away with things. And what happened with opioids, we're not getting away from that. We've got an opioid crisis here in BC, absolutely devastating, more deaths than car crashes, homicides, and COVID combined. And it still gets very little news. You don't get away with bad science around opioids. And perhaps if we had instead focused a little more on psychedelics and making educated laws, I can only assume there would have been far less deaths and a bit more clinical application. Yeah.
And so I think we could say that the psychedelics and psilocybin in particular are more important to our culture now than ever before, because as we're hearing, meaning has drained out of our culture steadily over the last 50 years, certainly over my lifetime. the old structures, the old cognitive structures that conveyed meaning and gave us a context for meaning. Our religious structures have pretty well decayed. Meaning coming from social connection has decreased in a dramatic way because of the advent of social technology. And the meaning that many people derived from contact with nature is slowly draining out of our social context as the environment gets worse and worse. And rather than seeing a future that naturally gives us hope for us and our children, we're seeing a much more bleak future. I think one of the characteristics of psychedelics is that they allow us to see a perspective on reality or the world that transcends the input from our senses. And when we're looking around the world and we see increases in disease, in environmental destruction, and poverty, all of that leads to despair and depression. Psilocybin allows the journeyer an insight into a much bigger picture where meaning is still available.
So where does that, what is the psychological context of a dying person, psychological, emotional, meaning context of a dying person that would bring them to a place where psilocybin is helpful, and why is psilocybin helpful in that context?
Well, the psychological context is personal destruction and annihilation. And the question we all ask, regardless of how atheistic we are when we're 30 and in a pub, the question we all ask is there something else that happens? Is this it? Does this consciousness continue in some way beyond death? What's going to happen, or is this the end? Is this all there is, as Peggy said? I mean, it's the crisis. We describe the crisis that people approaching death are experiencing as an existential crisis, because it is. It is a crisis of their existence. So that is the milieu in which people consider taking psilocybin or any psychedelic. How does psilocybin affect that, and how does psilocybin give relief from that? So the ordinary mind tends to function in a hamster on a treadmill kind of way. When you walk around the world today, Tuesday, thinking about your shopping list and what you're going to do on the weekend and what you did last weekend and how that guy did you in and you're going to get him back one of these days, you'll probably find you're having the exact same thoughts on Wednesday and Thursday and Friday. And all that's really changed is what's on the menu for supper or how far you've gotten in the book you're reading. And the circuitry that keeps us in that thinking mode, in that behaving mode, is known as the default mode network, quite appropriately, because that's the default mode that we fall into. And it's efficient, it gets the job done, it gets us through the world, but it's not very innovative and it's not very creative, and it tends to loop, it tends to go round and round and round, because that's the way it's set up. Psychedelics disassemble the default mode network. They disconnect the nodes on the network from the other nodes on the network. And so they reduce the brain into a much more creative, open, and receptive way of looking at life and looking at the world and looking at meaning. So receptive is the operative key, because then in that circumstance, then the brain can tap into, the mind can tap into larger fields of consciousness which are available. And in those larger fields of consciousness, which one cannot access if one is stuck in the default mode, there are answers, there are assistances, there are beings, there are all kinds of ways that we can achieve nourishment and help and enlightenment. And it doesn't matter how you interpret the assistance that you got or where you got it from. So a Christian would say perhaps it was from some angelic being or some saint that came to their assistance, or Christ or God. A Hindu would have other explanations, a Buddhist another one. It doesn't matter. But when you open into that zone of receptivity and you tap into the much larger field of consciousness, then you are opening yourself to a wellspring of energetic and emotional and spiritual assistance, which is quite simply not available to you when you're in the default mode. And this therapeutic modality, this efficient therapeutic modality, is available with psychedelics regardless of the diagnosis, whether you're suffering from treatment-resistant depression, whether you're suffering from terminal anxiety, or whether you're suffering from some kind of existential despair. The other thing that psychedelics do, more internally now, is they dissolve the resistance between the conscious and the unconscious mind. And so material that is in the unconscious mind but is being kept down by our active processes of resistance is released into consciousness and can be resolved. And a person who's dying is much more likely to resolve those things efficiently than someone who's meandering through therapy on their within their default mode network.
I also see that when people are faced with end of life, I mean, if you want to take this back to negative cultural paradigms, I think a real negative cultural paradigm we have right now is around how we treat death. And I think anyone working in palliative care would accentuate this, that we have a real society that likes to hide death. And where I believe in even some countries today, and certainly in the past, is when someone would die in a hospital or in care, they would be paraded out through the front door of the hospital. And now it feels much more like a situation where they're hidden, where we don't talk about this and where we don't confront our mortality on a day-to-day basis. Certainly that's why, humans, being perhaps the only animal that knows they're going to die, has created meaning and created religions that have a lot to say about death. As we move away from that and talk about it less, and the fact that we're certainly going to happen to every single person on this earth, it's kind of amazing that we don't talk about it more. If you have to undo that, and you have to undo years and years and years of avoiding your mortality, and the only tools that you have available are people who themselves may also be trying to avoid their own mortality and talking about it. That may be the clinicians or the people helping you. And then you're given drugs that suppress the anxiety and depression that comes up when you try to resolve that mortality. I mean, that's just a perfect storm of end-of-life distress, of anxiety. You're not going to get away with that. It's going to cause you pain and suffering. So finding using a psychedelic, in this case psilocybin, to undo that and to wake you up and to say, look, you're dying and there is meaning in your life. It's a powerful tool to undo that. It's a powerful way to make you realize that death is not the worst thing, that death is not the end, that it happens to everyone, and that yours is coming soon. And it's a way to prepare you for that.
I'm reminded of a conversation I had just a couple of days ago with a patient who will soon be undergoing psilocybin therapy. He talked about having a very difficult childhood, growing up with an alcoholic father and a very abusive mother. He talked about having made a number of serious mistakes in his life that he had a lot of regret for. And he talked about having considered suicide very seriously fairly recently. but coming to a decision that rather than just escape from all this unresolved material inside by suicide, he wanted to live his life to a point where he could resolve those things. He said to me, "I want to die whole." And that seemed to capture a very important truth for me. So this idea of the relaxation of the default mode network, the relaxation of our ordinary sense of self, and there's the relaxation of the avoidance that we usually have toward unpleasant experience. And one of the effects of psilocybin seems to be that it really relaxes our avoidance to experience. And one of the common results is the outpouring of emotion, that there's abreaction and catharsis and a purging, a cleaning out of emotional baggage that we've carried around for much of our lives. There's also a relaxation involving negative and dysfunctional thinking, and that's something that Robin Carhart Harris focuses a lot on these days, the cognitive side of the transformation that psilocybin involves.
Just to comment on what Bruce said, can you imagine how diametrically opposed that approach is to the standard psychiatric approach? And it's not really the fault of psychiatrists. You know, we work with young psychiatrists and they're trained and schooled in that methodology of suppressing things with drugs from the time they enter their psychiatric residency. Not wholly, of course. They do get taught therapy. They are encouraged to enter therapy themselves. It's not like psychiatrists are dull people. They're anything but. And it's not like psychiatrists are uncaring people. They're anything but. It's just that the system, and it has to be said, it is really fueled by drug companies. It's really fueled by the way studies are done and the way studies are funded. And it's really a toxic environment.
So this is maybe a little bit of a lateral move, and I'm thoroughly open to further exploring this topic on, basically something like why psilocybin works, which is kind of what we're talking about, like why do people stress when they're dying and why does it work? But what Sean had said there about sort of the role of pharmaceutical companies to direct the institutions and the priorities and the protocols within the institutions in a way that sort of would devalue, deprioritize, and even dismiss psilocybin types of therapies, sort of like root cause therapies or whatever it is, makes me think about, the amount of drugs that dying people are on, like a lot of drugs from what I understand. And in particular, cancer patients also on quite a number of drugs to try to control and mitigate the cancer, its progression, as well as the consequences of being in that state psychologically. And among those drugs are a number of things, but also quite a number of antidepressants, which again, like has been suggested over and over again, suppresses the symptoms, antidepressants, anti-anxiety medications, etc. And I'm wondering, as clinicians facilitating psychedelic or psilocybin therapy for patients dying with cancer, what protocols do you have to be able to assess the safety profile of psilocybin from a physical standpoint when there are so many other drugs or potentially other drugs in the system, including SSRI type antidepressants? And I'm just curious what your thinking is around that, what your protocol is around that. Yeah.
Well, you have to answer that question, you have to have an understanding of the receptor profiles of the medicines. So the essential receptor in the brain for producing a psychedelic effect is in the serotonin system, and it's called the 5-HT2A receptor. If that receptor receives a molecule that comes into it, and it's a lock and key type of phenomenon, and if the 5-HT2A receptor is blocked by another chemical, you could administer a boatload of LSD and a psychedelic effect will not occur. So when you're looking at drugs that might interfere with the psychedelic effect of psilocybin, your first port of call is the 5-HT2A receptor. You have to know if the compound that the person is on is blocking the 5-HT2A receptor. And if it is, they have to come off that, because otherwise it's not going to work. So quetiapine, for instance, which is a drug that's often used for anxiety and for sleeping, it's a new novel antipsychotic. It acts directly on the 5-HT2A receptor. And so if a person is on that, they're not going to have a psychedelic effect from, or it will be markedly muted. There's not too much in the way of safety issues, physical safety issues with most psychedelics and most drugs. They do interact somewhat, but the physical effects of them are usually not dangerous. We're looking more from the perspective of the 5-HT2A receptor. What's the relationship of the drug that they're taking to that receptor? Monoamine oxidase inhibitors, which are an old class of antidepressant, are very rarely used nowadays. They're generally have to be stopped completely, although psilocybin itself has a monoamine oxidase inhibiting effect, very slight, but it does have one. So really, it's a question, James, of knowing your pharmacology, and that's why we have physicians on the TheraPsil staff. And in fact, one of the things that we are doing, actively engaged in at this point in time, is building up a database of what drugs are problematic with psychedelics and what are not. The real problem in these situations arises when we need someone who has to be treated urgently. Bruce treated a woman last week who had maybe 2 weeks to live. And had she been on any contraindicated medications, he would have had to fly by the seat of his pants and give her the psilocybin anyway and hope they have an effect. It's generally not recommended to massively increase the dose of the psychedelic in order to overcome the effects of the pharmacology, because you just don't know where you're at. So we have 5 to 7 gram limit, which is a manly dose of mushrooms. And we won't go beyond that, even though they're on it. But it's a question of knowing the pharmacology of the drugs. That's how we do it.
And it's also worth mentioning here the dilemmas that we can find ourselves in when it comes to pain issues. We know that opioids generally tend to dampen the effect of psychedelics, but in a terminal situation where there's a great deal of pain, somehow we have to balance the mitigation of pain out with the benefit from the psychedelic. And in the woman that I treated very recently, she came into the session with a great deal of pain, even though the opioids that she had been regularly taking had been greatly reduced just prior to the session. But as she got into the midpoint of the session, the pain came back in a very big way, and she had to receive an infusion of fentanyl that really sedated her. And then later on in the session, where pain came up again, she received an infusion of lidocaine, which left her very sedated by the end of the session. However, what we saw it happen there was a real transformation for this woman in terms of her perception of her pain. The following day, she indicated that she had almost no pain. And it seems quite clear to me that the diminution of the physical pain seemed to go hand in hand with the expression of a great deal of emotional pain in the psilocybin session itself, that she cried nearly continuously through the session, but I got a sense that there was also a great relief from that crying. And so I really want to highlight this connection between the diminution of emotional pain and the lessening of physical pain.
I'll just add in a very small point here is that, like, this is, as both Sean and Bruce have mentioned, this is why we have clinicians on our team, why we have psychiatrists, medical doctors, therapists, and this is why we consult research. Is, although patients and doctors do have the right to move away from some of the strict parameters set out by research, they certainly do have the ability to use what we know to extrapolate and determine what is safe for some patients and what isn't. This is really how things should be designed, that the doctors and therapists should have the ability to decide whether or not a patient is right, so long as they're competent and educated, which our team at TheraPsil very much is.
Pain can be a real problem, a real issue. In the original studies in Baltimore, the Maryland Psychiatric Institute in Baltimore in the 1960s, they made no changes in people's pain medications. They kept them exactly as they were. Pain and hormone medication, they kept the same. Everything else they tried to modulate a lot. The drugs that will really block the effect of the psychedelics are the antidepressants and the anxiolytics. And the fact of the matter is that those drugs don't work for patients who are dying. Peeing in the wind.
And that was certainly true of the patient that I recently treated. I was joined in the session as a co-sitter by the patient's palliative care physician. I thought that was a very courageous step that she took. But she came to the conclusion that psilocybin was a wise choice because, as she told me after the session, she had thrown everything in her kit bag at this patient's pain, and there was virtually no lessening of it despite massive doses of opioids.
I'm wondering now, having, there's a lot of discussion that's coming up around sort of the relationship here between, emotional psychological pain, and we've talked about how that comes into existence from a lifetime of living a particular way, thinking a particular way, which itself is an expression of how a person was nested inside of the relational dynamics of their lives, which is also nested inside of a socioeconomic, cultural paradigm, and how that all contributes to total pain, and where psilocybin can intervene in that. And that also the sort of like modus operandi of psychiatric treatment for palliative patients is pretty much like something like throw drugs at the problem of the anxiety and the pain and the fear until it goes away, until you cover it up and it's not there, which doesn't work. And we've also discussed that this is not a lack of caring or a wanting to provide relief on behalf of the nurses and the doctors involved in that person's care. So I'm wondering, taking all of that, letting that float around, my curiosity is that if you could offer, if you could look at the way palliative medicine is currently being practiced, and what you're learning from the psilocybin work, what do you think are sort of basic toolkits or basic paradigm changes that would help change palliative medicine in a positive way and provide greater efficacy in care of dying patients, other than just including psilocybin?
Well, that's a question that I'm not qualified to answer, really, because I'm not an expert in palliative care, and the people that I have helped towards the end of their lives have been sporadic through the lifetime of my practice. Certainly, since becoming involved with TheraPsil, I am increasing my study hours on palliative medicine, and plan to up my knowledge, up my game, and that. But I would say in general that the palliative care physicians and the palliative care units do phenomenal work, absolutely phenomenal work. They are. I have no criticism of them at all. I criticize the application of anxiolytics and antidepressants across the board, not just in palliative care. This is the standard of care in medicine. It's not the standard of care necessarily in palliative care. And the people who practice palliative care medicine are heroes in my view. And also the amount of attention being paid to palliative care in practice and the amount of attention being paid to palliative care in research is increasing all the time. It was in the 1960s and 70s that palliative care really began to take off with, I can't remember the lady's name now, who started the first hospices in Britain. Cecily Saunders, was that Cecily? Anyway, Cecily was one of her names. And she began the whole hospice movement, and the people who work in these units, they give phenomenal care to people. And it is a dictum in palliative care that if you don't have pain control, you have nothing. There's no point in talking to somebody about quality of life when their bones are racked with pain from metastases, or they've rib fractures or spinal fractures. It's not nice dying of cancer. It's a tremendously difficult road to walk. And the people who assist them, the palliative care people, they're just among the most compassionate people in medicine. So what would I change in palliative care? I am simply unqualified to answer that question, and I won't even attempt to try. Apart from the addition of psychedelics, I want to bring psychedelics into palliative care. I want to educate palliative care physicians and nurses on the huge value of psychedelics in this field. A comment, just reverting back to the pain issue and the fact that this lady that Bruce treated had a great resolution of her pain. When one takes a psychedelic substance, one enters realms of the human psyche that can be classified into broad categories. The first is biography, the time from birth to now, the kind of realm that every psychotherapist knows how to deal with, whatever their system. But when it extends beyond that, then people can get into reliving experiences from the time in the womb and from the process of birth. And then beyond that into the transpersonal realms. And these are the realms where one meets spirit guides and shamanic entities and has those kinds of larger experiences that are not confined to the body, ego, mind view. And there's very little actual change in pain generally in psychedelic work with cancer patients, except the patients who stay very strictly in the biographical realm. The patients who spend most of their time working with personal issues, loss of friends, loss of family, and the person that Bruce treated who fits this category, her family was in the room at the time when she was treated. She had a real 10-minute period of just holding her hands up against her father and some kind of energy exchange without words happening. Very biographical kind of experience. And that is the kind of person that is most likely to get relief of pain. And it is, as you said accurately, James, it is a dissolution of some of the anxiety and the tensions around these issues that have, those anxieties and the tensions have been added to the pain and amplifying the pain. And if they can be relieved, then the amplification process goes down. But in general, it is unwise to expect a resolution of pain in a cancer patient from psychedelics.
And similarly, I'll say that, you know, the palliative care community is doing a phenomenal job. And if anything, they should just have the dignity to be able to experiment with these medicines with their patients. And I think it's something that is very well accepted in palliative care. So as for their toolkit, what they can improve, perhaps there's room for psychedelics in that toolkit. Perhaps there's room for a move to therapies that were, new therapies, new novel therapies. I really do think, though, that they are the ones innovating. And it's certainly present in the acceptance of medical assistance in dying, which is, here in Vancouver Island, this is the epicenter for it worldwide. It's incredibly, this is the most progressive health palliative care community perhaps in the world, jurisdiction in the world, especially with the new use of psychedelics such as psilocybin and ketamine. So I would just say that they've got to keep doing they should keep doing what they're doing if it's working. And certainly this patient that Bruce treated saw a resolution to her pain. I know that one of the other patients, Lori Brooks, who's been very public about her use of psilocybin, said that she couldn't move her arm until she went through her psychedelic experience, at which point feeling and sensation came back to it. So there's certainly something psychosomatic, and perhaps there's some resolutions. But as Sean says, you're absolutely never going to find a complete resolution to pain, because these are horrible diseases, and very, very painful ones.
I'd like to return to this question of what has to change in palliative care. My sense is that a tremendous amount has already changed. I mean, if we compare palliative care today to palliative care of 40 and 50 years ago, well, it's always been about helping a dying patient to remain comfortable. But back then, the comfort was more seen as about the physical level. Yes, it could include the psychological and emotional levels, but now we're seeing much more openness amongst palliative care workers to addressing the distinctly spiritual aspects of human life. So the palliative care physicians and therapists that I've spoken with over the last year or so, they are all very open to framing the patient issues in spiritual terms and spiritual paradigms. There's lots of talk these days about life meaning, about purpose, about the possibility of transcendence, use of spiritual categories like forgiveness, redemption, love, and spiritual practice. It's very difficult sometimes to distinguish between the language of palliative care workers and pastoral counselors.
So maybe this curiosity ends up bringing us to closure, which is that we've been talking about psilocybin for dying patients in general in the context in which it is happening, and references to the work TheraPsil has been doing insofar as providing that therapy. And maybe to close out, we could get a sense of what it has taken in order to get there. From in Canada, it's like Schedule 3 rather than the U.S. Schedule 1, but it's basically the same. To go from it being flat out illegal, not allowed, no, stop, don't, psilocybin in any case, to being able to provide it to dying patients. Like, what has TheraPsil done in order to achieve that? What did it take to get there And what did it take to get there?
So I can say the least about this, so I'll start. I have been very impressed with the intelligence of Bruce and Spencer in their approach to this. And I'm going to let them speak about that approach because I don't know it in detail. But I would think that a larger context in which TheraPsil has been operating in is the shift in society's awareness of psychedelics as not being the spawn of Satan, but rather being useful tools. And I think that MAPS has played a huge part in that. Your podcast, James, is widely listened to and widely appreciated, and it offers a very non-sensational, factual-based, conversational approach, which is precisely what is needed because these drugs are not the spawn of Satan, and neither are they, as our great friend Saint Timothy Leary said, neither are they going to be the salvation of humanity necessarily. They are tools, they have a role, they have limits, but they should not be banned.
Bruce, perhaps I'll let you speak first.
Yeah, I guess as I look back over the last 5 years that I've been actively pursuing access for patients to psilocybin, and I ask myself, well, what have I focused on? Well, I seized really early on the science, and I followed the science very closely because if we think back to the major court rulings, the judges are affirming a Canadian's right to make their own medical choices, but it sounds like that right has to do with those choices being reasonable medical choices. And how reasonable the medical choice is really depends on the science behind it. And so one thing that we've seen over the last 15 years is this incredible step forward in terms of the science. We've got landmark random controlled trials that are peer reviewed, and I haven't seen any serious objections to the quality of that science. So things are moving ahead month by month, almost on the scientific forefront. The other big thing that has been important to me is the idea of rights. And so the fact that there have been several landmark cannabis cases that have affirmed the right of Canadians to cannabis, well, we can easily boilerplate psilocybin into those judgments and see just how cogent they are to psilocybin. Another thing that I think that we're seeing is the fact that many of the hippies that took LSD and psilocybin back in the 60s and the 70s, now they're kind of coming around for a second dose. They're now entering elderhood and in some cases the end of their lives. And they already know from their early experiences in youth that these things are not spawns of the devil. And so they're embracing them with a lot less fear than subjects would have embraced them originally in the 60s.
And some of them are in high positions in the government and bureaucracies. They didn't all go fishing.
And so I'll add my perspective here on this is like we stand really on the shoulders of giants here being in Canada. Like what's happened in the last couple decades here is incredible. Again, with cannabis and patients getting rights to cannabis, Sue Rodriguez and her fight for right to die. Not to mention, of course, all the amazing work that was done in the 50s and 60s around the legality of these, or around the effectiveness and safety of these substances. It's really, it's really just about time here. Bruce obviously started this work with an application a couple years ago. I believe it was 2016 or 17. And what it took to get here was just a slight shift to really focusing in on the patients and individual stories, and bringing back the lessons learned from those court cases and around the right to die and around cannabis, which is people have the right to their own medicine, and the government does not get in the way of that. Specifically when we have dying patients, and you can make their stories known, and if those dying patients are willing to come out of the woodwork and say, here I am, minister, and here's what my personal life looks like. Are you willing to help me? It's putting pressure on those officials, and as Sean says, hopefully a lot of those officials know what these drugs really are, and so they're open to creating treatment options. I think our health minister Patty Hajdu once said in an interview that she's open to the idea of legalizing drugs, but that's got to start with treatment options. And so that's what this is a treatment option, and a team that really stands on the shoulders of giants who created legal access to ayahuasca, to cannabis, and to medical assistance in dying.
So another thought has come up, and so I'll just introduce it here. Is there a concern for you that the decriminalization movement, which is sort of happening concurrently with the medicalization movement, is going to harm or hinder the progression of medical access to psilocybin, be it for dying patients or otherwise?
Portugal. So all drugs are now decriminalized in Portugal. The sky has not fallen. And I think the only thing that could limit that access would be if there were some kind of horror stories. And those horror stories are not happening in Portugal. They're not happening in Holland. The biggest horror story in Holland is all the tourists coming in to smoke pot in Amsterdam and pee in the canals. And I worry about that a little bit, James, but I think that, psychedelics have in fact been widely used for the last 50 years. They've been essentially decriminalized because the police are not going after kids taking mushrooms or a hit of acid on a Saturday night. They've got much more dangerous and difficult tasks to look after, and they're not particularly worried about it. And so there's, in essence, been widespread use of psychedelics in our society for a long time, and the sky has not fallen. And I've been practicing emergency medicine for over 50 years, and I've only seen one case of cannabis, not counting the cannabis vomiting syndrome, which can bring people to emergency room. But I've only seen one case of problems with cannabis, and that was when a mother brought Johnny in for me to fix him because she found a joint in his backpack. I used to see people in emergency departments with freakouts from LSD and psilocybin in the 1960s, but actually you just don't see them anymore now for two reasons. Firstly, people themselves have gotten much more sophisticated about managing challenging moments in psychedelic journeys. And secondly, they expect them. People who do serious psychedelic work expect to find some rough patches. They expect to see a process of purification before the ecstasy. And I think that once psychedelics are introduced, there won't be big problems. I would prefer to see them used in sacred and ritual ways. I would prefer to see them used in situations where people carve off some time out of regular time and go into sacred space or medicine space and work on them in that way. But I don't think there's going to be a major problem with these compounds.
And I'll certainly second that there's likely going to be no issue with decriminalization. I mean, if you look at what the Justice Department just put out, their new prosecutors' guidelines for how to deal with prosecuting folks that are using psychedelics, and in fact, all illegal drugs, if they're using them for medical purposes, if they're indigenous and using them, that they've actually said, prosecutors and police officers, there's no sense in, providing the maximum penalty to these folks. We need to look at this more as a mental health issue, rightfully so. So obviously that doesn't give anyone in Canada the permission to start dealing drugs or using them illegally, specifically if you're endangering children and at-risk people. But certainly we're moving towards that direction of decriminalization slowly. And that's the way politics works in Canada. But it's most certainly moving that way. And I certainly see a lot of other countries doing, similar to, or acting similar to the way that the Netherlands and Portugal has. So I'm excited for that. However, we also have to confront the medical community and our government and say that decriminalization does not mean medical access. They're two separate things, and they both need to happen at the same time. So certainly support the decriminalization effort. I really don't think that anyone should go to jail for their personal use of psychedelics. And absolutely at the same time, we are going to push forward with the medicalization of these substances.
Yeah, personally, of course, I support decriminalization, and I believe the good things that I'm reading about the success of that in Portugal. For strategic reasons, though, I've all along wanted to play this game fairly conservatively. I have focused only until very recently on the needs of dying cancer patients, because I thought that was the one area where no intelligent person with a heart could refuse these dying people their wish for some comfort and relief before they pass on. So I'm content that TheraPsil continue to focus on the medical aspects, and as we move from the needs of dying cancer patients to the needs of other terminally ill patients, and then from terminal illness issues move out toward things like treatment-resistant depression and anxiety and addictions and PTSD. I'm confident that the decriminalization movement is moving along fairly well now. It will come to a place of completion, but it's not a battle that TheraPsil has to focus on at this point.
It seems like there's that the trajectory we have taken as a civilization, in particular as a society, like North American societies, has not boded well for our mental, emotional well-being, our relationships, or our, including our relationship to the natural world, the presence of a healthy natural world, or the ability to die with dignity. And in many ways, I feel that the well-held, positively experienced psilocybin experience can get to the root of a lot of the damage that society and civilization has done within us. And in time, I would hope that that undoing manifests through action personally and collectively can help undo some of the institutional issues that we have that's causing the problems, and maybe autocorrect this thing we've got going, get it out of the reeds before it goes over the cliff, kind of thing. Yeah.
Well, I would hope that also. On the other hand, I've seen jerks take psychedelics for 20 years and remain jerks. I think that there is a big difference between having a psychedelic experience and integrating that experience. And Integration is a subject we haven't spoken about that much because we're dealing with terminal patient cohort, and so they're pretty one-pointed in their desire for what they want to get out of the experience. So if it's difficult to integrate psychedelic experiences individually, I think it's going to be equally difficult to integrate them as a society. However, that being said, James, I think your question is germane, because I think a lot of the things that are positive in North American society and Western society in 2020 are a result of 50 years of psychedelics in the society. So I don't think that the changes are going to be dramatic until we are faced with really dramatic problems, which if you live in Washington or Oregon right now, you're certainly experiencing them. So what role will psychedelics play in the transformation of society? I would hope a big one. I would hope an intelligent one. And I would hope that there would be an understanding of the fact that a psychedelic experience is a bit like cut flowers. They're very beautiful when you put them in the vase, but they start to fade immediately. And the more you can nurture them, the longer they will last. Psychedelic experiences require the same kind of care. Otherwise, the world would be littered with enlightened hippies, and it's not.
I think that what psychedelics may do as they become a bit more generally accepted in psychotherapy is allow people to first and foremost, get their own houses in order, get their own lives in order. I think that's where a broader change in society starts from, is at the individual level. And so if modern therapeutics or therapy at the moment isn't very effective for a lot of people who, as we've been talking about through this conversation, may not have a clear indication of what their life meaning is and the importance of their role in society, that perhaps psychedelics may help some of those hard to treat cases, really understand their purpose in the world. And obviously some of that can be the result of, childhood or developmental traumas, but sometimes it's not, and sometimes it's a bit easier to solve. And so while I certainly don't think that psychedelics is going to solve all of our issues, I really do hope it'll help those really hard to treat cases that really struggle. And if we can help those people and we can help ourselves, that's what changes society is the individuals. It doesn't happen on a larger level from the top down. It works from the bottom up. So people finding it themselves, their ability to heal themselves and then fix the world around them is going to be pretty important. And that doesn't always get taught to you after a dose. That's the work of these therapists on this call here, to make sure that while you're in it, you're actually learning something.
I guess I'd like to close just with a brief quote that sums up the science that we now are clear about when it comes to the use of psilocybin with end-of-life issues. The Hopkins team says, quote, psilocybin produced large and significant decreases in clinician-rated and self-rated measures of depression, anxiety, or mood disturbance, and increases in measures of quality of life, life meaning, death acceptance, and optimism. These effects were sustained at 6 months. I'd like to close by saying, right now I'm feeling a fair degree of pride in being a Canadian. Canada was a world leader in psychedelic research in the 60s. We had a large hospital in Weyburn, Saskatchewan, that did some cutting-edge research. And it's interesting that the first legal treatment involving psilocybin in Canada in 40 years happened in a town, Saskatoon, that is fairly close to Weyburn. Canada is now again, a world leader in psychedelic medicine. And I am just delighted and happy and thankful and humbled to be part of that cutting edge.
Okay, on that, we'll have this be a sign off. I want to thank each of you, Sean, Spencer, Bruce, not only for coming here and sharing your time and with us here on the podcast, but also for the work that you're doing for patients and for Canadian healthcare, palliative care through TheraPsil. So to each of you, thank you very much.
And thank you, James. I really appreciate the work that you're doing. We couldn't do the work that we're doing without folks like you doing what you're doing.
Thank you.
Yeah, I'll certainly echo that. And also, just because I realized it wasn't mentioned on this call, but we owe a huge thanks to our friends in government, Patty Haiju, everyone who works at the Office of Controlled Substances, and a couple of Canadian MPs who have really allowed these patients and ourselves to be heard within the government. So, they've certainly had a huge role to play in all of this.
Hedy Fry, Marcus Pulowski, Nathan Erskine-Smith, Helena Jasek, very helpful to us, and we're deeply grateful to them as is their patients. Yeah. You're muted, James. You're muted.
Oh yeah, okay. Well, man, it's such an admin fail, tech fail there. What I was saying was, and cut. Thank you very much for tuning into this episode of Adventures Through the Mind. If you enjoyed it, please share it with a friend. If you found it valuable, then please share it with a friend or share it with somebody who you feel will be able to glean a similar sense of value from it. If you think what TheraPsil is doing is interesting and meaningful, I highly encourage you to head to TheraPsil.ca and take a look at what they're doing, the impact they are going to be having on the medicalization of psychedelics here in Canada and the integration of psychedelic therapy into the Canadian medical institutions is only just blossoming. So getting involved with them, paying attention and following up, following along with what they're doing, and possibly reaching out to support them if you feel like you have that capacity and that interest, I think it's valuable just period. So check them out, TheraPsil.ca. That's it for now. Thank you for tuning into this episode of Adventures Through the Mind. I will see you on the next one. And until then, take care.